along. So I'm really glad to give a brief introduction today to Dr. Elena Losina. She is, as you can see on the slide, the Robert W. Lovett Professor of Orthopedic Surgery at Harvard Medical School, and she directs the Pivot Center as well as OrACORe that many of us are familiar with. A handful of us on this call have had the privilege of working with her on a variety of different studies dealing with osteoarthritis, economic analyses, and trials. And she's going to be talking to us today about the value of knee OA treatments. Elena, all yours.
Thank you so much. Thank you, Kelly. And special thanks for pronouncing my last name correctly. It happens so rarely that I notice it every time. So thank you. So thank you very much for inviting me. And I just came back from a conference, and as in many conferences, you see speakers that speak kind of in a right pace and speakers who speak very, very fast because they're trying to deliver a lot of information. So we'll see how I will be doing today because I do want to share a lot of information. So we'll see. If you have a question, please put it in a chat. And Kelly, if you don't mind, I will ask you to kind of to check the chat to make sure that if I need to pause to address the question, please let me know. Thank you. So again, today we are going to be spending our hour talking about value of new way treatments. It will be mostly US-centered talk because you cannot talk about the costs around the world. You do need to have a geography specific. And so today's talk will be focused on US, but the methods could be definitely very, very easily adapted to different settings. Okay, so now I'm trying to figure out how to move the slides. Okay, great. So the prevalence of osteoarthritis is over 7% of people globally. It's greater than 500 million people. Okay, 1 second to do something. And it's even higher in high-income countries. So in US, for example, it reaches 14%. Most frequently affected joints, hands, knees, hips, and obesity knee injuries, two major risk factors for symptomatic knee OA, have become more prevalent in recent years. And these trends may contribute to early OA onset. Patients' demands for early and more aggressive treatment may contribute to early presentation to care, and early presentation to care may lead to unprecedented utilization of health services, including total knee arthroplasty. And also direct-to-consumer advertisement of some treatments, even of questionable efficacy, also adds to increased treatment demands. So from economic perspective, given that prevalence of OA reaches 7 to 14% in high-income countries, the direct medical cost amount to 1 to 2.5% of GDP. And high economic burden in OA is due to high prevalence coupled with longer life expectancy. How medical costs are evaluated. It includes all direct medical costs in OA patients associated with frequently occurring multimorbidities. And in 21st century, OA is the second costliest medical condition treated in US hospital, primarily due to increased volume of total joint arthroplasties. The prevalence of absenteeism among individuals with arthritis-related chronic knee pain ranges from 4% in Netherlands to 71% in Canada. In US, it's somewhere in between. So CDC put together a very nice infographic, which is a few years old by now, but I think, speaks quite a bit to the economic burden. So 1 in 7 adults have osteoarthritis with annual medical costs reaching $65.5 billion. And average per person per year medical costs seem to be relatively small, just $2,000. But again, because of a very high prevalence, that ends up being costing quite a bit. And in addition to direct medical costs, there is $71.3 billion spent in annual earning losses, just a few big picture numbers. OA has a quite substantial impact on remaining quality adjusted life expectancy. And among people who are age 65 to 69, it takes away about more than 10% of their quality adjusted life expectancy. And as population is aging, then it takes much more. And so for those who are 75 to 79, more than 20% of their quality adjusted remaining life expectancy is being lost due to arthritis. The challenge is that with this such a high burden in people around the world, we don't have that many treatments to offer. And so average time spent living with symptomatic knee osteoarthritis is about 28 years. And how those 28 years are being spent in terms of treatment. So about 3.2 years, people are trying to all those non-surgical regimens, including the PT and NSAID. And then another 2.5 years, most of the population are trying at least once to use the injections. And then the next option, the viable option, it's actually total knee arthroplasty. And so that leads to 13 years that people with knee osteoarthritis are struggling, trying to figure out how to manage their pain because they're not quite ready for total knee arthroplasty, or the knee arthroplasty is not quite offered. So that offers great opportunity to fill that gap. But as of today, we don't really have much to offer. So among the options that we have, which is, I mentioned, not that many, let's now switch to understand, how to evaluate treatment, or how to evaluate care for knee osteoarthritis specifically. So let's start with defining what is the low value treatment, how it's defined. So there are different classes of low-value treatments, and it can be defined as care that offers minimal or no benefit considering the harms, the cost, and alternatives. So there is a hierarchy of low-value treatment, and the class number 5, which is actually quite a big class. I'm sure that we have somebody who knows somebody who knows somebody who told that there is this magic pill or magic gel or magic injection that will cure the arthritis, or even better, some special food. So then there is no reason mentioned, and it just, being word of the mouth saying, oh, this is a great treatment. You just need to put out a few $1,000s, a few $100s, and you'll do great. Class 4 includes those with insufficient evidence, so the evidence that comes from very, very small case series, and it's almost always being promoted by the manufacturers, so we see a lot of it on social media and internet. Class 3 has little or no clinical benefits, and again, this is a very controversial class because there are some treatments or some regimens that offer very little benefit but also don't cost much, and they may be considered as a valuable care option, but some that offer no direct treatment effect, they probably do not contribute to the high value care. Then the next one is no net clinical benefit, then where the risks or harms outweigh the benefits. And class number 1 is the ultimate kind of top of the pyramid. It has the low economic value, so low cost effectiveness or high economic burden. So the way that to assess the class 1 of the low value care is by performing the cost effectiveness analysis. Cost effectiveness analysis is a formal methodology that considers 2 different outcomes, cost and effectiveness. And effectiveness is often measured in quality adjusted years of life saved. The main reason to use QALYs, and some people love them, some people hate them, some people don't understand how to ascertain them, is because the goal of the economic evaluation to provide some matrix to the payers to understand how to share limited resources. And providing the effectiveness in disease-specific terms makes it very difficult for the payer to figure out how to distribute the resources between the dollars per WMAC unit versus dollars per some other effectiveness unit. And so that's why quality adjusted years of life is considered to be a universal measure of effectiveness that helps the payer to rank and compare value of treatment across different conditions. So the main outcome of cost effectiveness analysis is incremental cost effectiveness ratio that is calculated as the ratio of additional resource use over additional health benefits. And it expresses the value of resources spent. And this value is compared to the willingness to pay threshold, and it can be setting specific and often payer specific. So in United States, we don't have a very clear definition of willingness to pay threshold because our payer system is disintegrated. So there is a government, there are some private payers, and so everybody establishes their own willingness to pay threshold. Historically, $50,000 per QALY has been used as the willingness to pay threshold, but this is the value that has been introduced about 30 years ago. And so now I think the updated value that we're seeing more and more is $100,000 to $150,000 per QALY, consistent with the GDP. This is the graph that tells us or shows the association between the GDP per capita around the world and willingness to pay per QALY. And again, theoretically, it's considered that there should be some association between the willingness to pay threshold and GDP. And this graph shows that it's not quite clear whether this such association exists, especially linear association. Some kind of state that the willingness to pay should not increase the 3-time GDP for the upper boundary of cost effectiveness. Some say that it should be 1-time GDP to be very cost effective. But this shows that, if $50,000 for USA, it's much lower. And I think, reaching the 100,000, that gets us to close to be the 1-time GDP. The GDP in the United States, I think, now approaching $170,000 per person. This slide shows a graphical representation of the cost effectiveness analysis. And so let's say that we're trying to evaluate the cost effectiveness of a new treatment or new regimen. And C is our regimen as a standard of care that we're comparing to. So the new treatment can be more effective or less effective, and the new treatment can be more costly or less costly. And depending on these two parameters, how effective it is compared to the one that we're comparing to, and how costly it is, the new treatment characteristics will end up in one of those 4 quadrants: Q1, Q2, Q3, and Q4. So let's start with the easy quadrants. So if the new treatment is more effective and less costly, it's no-brainer. You do not need to do a formal complicated analysis because it's clear that this is a cost-saving treatment. And we wish we would have more of those, but we have very, very few. If we have treatment that is more costly and less effective, that's quadrant 4, nobody wants such a treatment. So that's also an easy conclusion. So the challenging conclusions are if the new treatment ends up to be in quadrant 1 or quadrant 3. So that will depend whether, to assigning of a value of such treatment will depend on this dotted line, which represents the willingness to pay threshold. And if the treatment ends up to be below the dotted line in quadrant 1 or above dotted line in quadrant 3, that is how the high value is being defined. So trying to put a little more annotation in this cost effectiveness plane, I think the lower kind of part of this plane represents high value care, and the upper part represents the low value care. And then, the white segments, that's the gray area, and that's where it depends on the willingness to pay thresholds. So let's go back to our knee OA treatment. So this is a complicated multicolored slide, but what I try to do is to enlist all potential options for knee OAs that we have that are mentioned at least at one clinical guidelines, and that includes exercise, weight loss, non-steroidals, intra-articular injections, hyaluronic injections, tramadol, opioids, arthroscopic partial meniscectomy, PRP. There's a lot of controversy on that, and total knee arthroplasty. I did not kind of look at them, did not put the stem cell injections because I don't think that there is any clinical trial or clinical guidelines that mention this yet. And so different colors represent different set of recommendations, and columns represent different organizations. So we have ACR, OrACORe, AOS, and then some international organizations. So what is, I think, useful to recognize that for most of the clinical guidelines, exercise and weight loss uniformly is being recommended with some question mark for SKO, but hopefully they will change their recommendations. Similar recommendation exists for NSAIDs, and again, so the green and light green goes for strongly recommended and conditionally recommended, red goes for recommended, strongly recommended against, and pink goes for conditionally recommended against, and yellow means there is no clinical recommendations because of unclear efficacy evidence. That said, there is a variety and there is a heterogeneity on those recommendations, with exception of one, exercise and weight loss. But this is surprisingly, this is the recommendation that is uniform in all clinical guidelines, but it has the hardest time to be implemented, and primarily because of who is going to pay for it. So I think, based on this differences of heterogeneity in recommendations and based on the variety of treatments that are being offered, so the question is, which ones represent the high value for treatment of knee osteoarthritis? And so among non-pharmacologic, we have diet and exercise and, specific exercise information. Among pharmacologics, we have NSAIDs, tramadol, and opioids that, had been in fashion a decade ago, especially in the United States. Now they're falling out of fashion and being exchanged by gabapentin and occasionally duloxetine. Then there are intra-articular injections such as corticosteroids, hyaluronic acid, and PRP, which has a lot of controversy. And then there are surgical interventions, APM, with the number of trials suggesting that partial meniscectomy may not be very effective compared to non-surgical treatment. But again, both PT and APM provide some benefits. There is bariatric surgery for people with excess weight, and there is a total knee replacement. And in total knee replacement, the questions, while the procedure overall has been shown to be very cost effective, then the questions are, what about the value of TK innovation that is often used to promote different surgical approaches? And what about using total knee arthroplasty for a person with morbid obesity, which also receives a lot of questions and concerns. So in the next 40 minutes or so, I will go over the assessment of value of quite a number of these treatments, including diet and exercise, and opioids, and gabapentin, intra-articular injections, and some of the surgical interventions. In providing the evidence of cost effectiveness or not providing such an evidence, I will use the OrACORe model. So this is a computer simulation model of knee osteoarthritis natural history and treatment. This is the validated and widely published model that had been NIH funded since 2006. We're also grateful for co-funding from Arthritis Foundation that in early stages of OrACORe provided funding to establish to provide initial evidence for the value of total knee replacement. And now we're working with Arthritis Foundation to establish the value of GLP-1s. Pfizer provided some funding to establish burden of opioids. The model has an international group of investigators, and since 2006, we published 89 peer-reviewed papers, and that had been collectively cited more than 7,500 times based on Google Scholar. And half of OrACORe papers are in the top 75th percentile by eyesight NIH index, and about 30% receive top 5% public attention from altmetric scores. So I think, the evidence we provide has been noted and has been read, and the next push is to make sure that it's being implemented in clinical practice. That is a kind of important next step. So how the model works, this slide shows the 30,000 kind of above the ground view how it works. So we generate the cohorts of people based on their demographic characteristics, age, sex, and race, and clinical characteristics, including obesity, chronic diseases, physical activity, and knee pain. And the model acts in the set of transitions, and some transitions run through annual transitions, some specific analysis we run through more frequent transitions, and those health transitions are count or encounter the changes to cost and quality of life due to new structural changes, pain change, BMI change, physical activity changes, and status due to OA, obesity, or physical activity regimens, or death. And the outcomes are accumulated cost and quality adjusted life years. And one of the best kind of traits of the model that we have we have no loss to follow-up. So the model tracks everybody who enters the model, and we track for most of the analysis until everybody dies. So let's start with non-pharmacologic regimens, and diet and exercise are obviously the ones that are being recommended by majority of clinical treatment guidance. We had been fortunate and blessed to collaborate with Steve Messier and his team on now three trials. So the first one, I will present results of value of diet and exercise, data informed by the IDEA trial. So the intensive diet and exercise for arthritis trial showed that a 10% weight loss combined with moderate exercise results in about 50% reduction in pain in older adults with chronic knee OA. And so we took the data from the trial and coupled it with the data on from national cohorts on the comorbidities and cost of various treatment. And we established the cost effectiveness or conducted cost effectiveness analysis from two perspectives: healthcare perspective and societal perspective. So the difference between those two perspectives is societal perspective. In addition to cost related to direct medical costs, also include the productivity cost. And so we compared two interventions, one usual care and another one usual care plus diet and exercise. And so the rest of the analysis that I will show in this presentation will have very similar format as this one. So I'll spend a minute or so to describe what they mean. So the third column is quality adjusted life expectancy. The next one is lifetime cost, and the last one is incremental cost effectiveness ratio. So each strategy leads to the quality adjusted life expectancy and lifetime cost, and then the incremental cost effectiveness ratio is the difference between cost over the difference of qualities. And so from healthcare perspective, the incremental quality cost effectiveness ratio for diet and exercise is 34,100 dollars per quality saved. And this is a very favorable compared to any willingness to pay threshold that has been used in this country. And if we look at societal perspective, where we take into consideration the productivity cost, we also see that the cost effectiveness ratio decreased slightly quantitatively, but qualitatively it really looks very, very similar. So the question is, if it has such a favorable cost effectiveness ratio, why we're not implementing it in day-to-day practice? And that's where, we'll talk a little bit at the end. The evidence of cost effectiveness does not provide evidence of affordability. So for example, in real life, we all may say that, I don't know, BMW potentially, will have a favorable cost effectiveness ratio compared to let's say Ford Focus, but it does not mean that everybody can afford or will be able to buy this expensive car. So in order to implement strategies, we need to have an evidence of cost effectiveness, but we also need to understand what is the budgetary impact. And often the economic evaluations stop right at the evidence of cost effectiveness, providing very little information for payers what will be the budgetary impact, and not that much information for the healthcare systems how to implement and where resources will be coming from. So this is a challenge that we all as a research society and policy group would need to figure out how to overcome. So the idea was a beautiful trial that was very convincing, but it was a clinical trial, efficacy trial, which was done in a sterile academic environment. And that was followed by the weekend trial that was pragmatic trial done in a community to establish the effectiveness of the diet and exercise program as well. And we again collaborated with Dr. Misael's group to establish the cost effectiveness of this community-based intervention. And so this is a slightly different analysis because the trial compared the health education and diet and exercise. It did not have usual care group. So the usual care group that we used in the analysis was modeled after the data from Osteoarthritis Initiative, which shows that's its observational study. And this is the same format. So we have quality adjusted life years, cost, and incremental cost effectiveness ratios from two perspectives, societal and healthcare perspective. So let's look at the incremental cost effectiveness ratios. So for health education, that was one of the arms considered in a trial. The incremental cost effectiveness ratio compared to usual care was 3,400. And for diet and exercise compared to health education, it was 25,800 from the societal perspective. So some of you may say, well, 3,000 is actually less than 25. Why is it we're concluding that diet and exercise is cost effective? What about health education? So the methods of cost effectiveness, so the idea is to establish the value or to state that the cost effective strategy is the one that leads to the highest benefits without exceeding the threshold for willingness to pay. And that's why this analysis points that diet and exercise is the cost effectiveness strategy, because again, it gives us the highest quality adjusted life expectancy without surpassing the threshold. The next question, I think, some of you will say, well, but the difference in quality is so small. Why do we even care? So again, this is the methodology by which we can compare treatment. And we need to remember that osteoarthritis is not killing people. It just makes their life somewhat miserable. And so that's why the differences in qualities are relatively small because the treatments people are staying on are relatively short term, while the disease itself, lasts for 28 plus years. So the next question that we try to address, and that's the concern that we always hear about all physical activity interventions. Well, you can only sustain doing the physical activity intervention for a short period of time, and whether the short-term physical activity intervention add any value to NEOA care. So what we use the OPAL model, try to understand, take into consideration, what if there is a short-term physical activity program, and what if we only 10% of the population who are inactive with knee osteoarthritis would participate in that program. And so we estimated that participation of 10% in a model PA program could save 200 cases of cardiovascular disease, 400 cases of diabetes, and about 6,800 quality adjusted life years. And that such PA program with maximum 3-year efficacy in the NEOA population carried favorable long-term clinical and economic benefits, resulting in the incremental cost effectiveness ratio of $16,100 per quality in those who were inactive. And if it's offered to everybody without assessment or of eligibility based on physical activity, then the incremental cost effectiveness ratio increased to $31,000 per quality adjusted life year saved. So again, both results again show that it's favorable from the cost effectiveness point of view. In the next step, we all need to push in how to implement and how to provide to our peers kind of evidence of affordability. And we've done some work on that trauma as well, which I'm not going to cover in this talk, but that has been done, and hopefully it will be helpful for the peers to make right decisions. Let's move to pharmacologic regimens, because the reality is that in the United States, for sure, patients come to see doctors to ask for some pills, magic pills that will take care of the pain. And so there is a good and a bad part in such a desire. So the regimen costs or drug costs that are used for knee osteoarthritis, primarily they're all generic. So they're very inexpensive compared to others. And so the only ones that, reach a couple of $1,000s, that's the brand names. But right now, nobody is using the Proxen brand. So it's a generic drug and it's very inexpensive. The same thing, the celecoxib that, the brand name is much more expensive. And recently the celecoxib also became inexpensive. And what is even worse than all the opioids are quite inexpensive in terms of the drug cost, but they're quite expensive for the society. And gabapentin and duloxetine also cost pennies. So the cost of each of these pharmacologic regimens is not high, and it potentially can give this perception that, if they're cheap, that maybe, offering some high value care. So let's see what's going on. So what are the economics of opioid use in osteoarthritis? So it's not just the cost of the medication, but the major concern is related to illicit use. So we estimated that per prescription, there is $200 go toward illicit use. And assuming that, those who are taking opioids on a regular basis get 6 prescriptions per year on average that we derive from Medicare data, that results to every person who is using opioids in OA, $1,226 go out toward illicit use. And when you sum it all up, that $14 billion are being spent on opioids, and about half, or $6.5 billion of this cost, were attributable to lost productivity, criminal justice, and diversion cost. And the annual societal cost of opioid use in the population is approaching $500 million. So while the drug is cheap, the consequences of using that drug are quite expensive. And when we conducted the cost effectiveness analysis, formal analysis, looking at the value of tramadol and tramadol followed by oxycodone in those in whom tramadol stops providing any pain benefits. So we looked at those several strategies: opioid sparing, tramadol only, and tramadol plus oxycodone. And so what we found is that because of the risk of adverse event, neither tramadol nor tramadol followed by oxycodone showed to be offering good value in if at all. So they costed more and resulted in less benefit, and therefore were dominated. So opioids do not appear to be cost-effective in OA treatment, and principally because of the negative impact on pain relief after total knee replacement, because the chronic opioid use led to suboptimal outcome post-total knee replacement. And so while the total knee arthroplasty utilization did decrease a bit in those using opioids, but it did not decrease substantially, going from 66% to 59%. What about people who do not wish to take total knee replacement, total knee arthroplasty? There is not everybody is willing to undergo that. So we did this analysis stratified by different age, 50, 60, and 70. And so here we are moving from dominated to the tramadol is offering a reasonable value for those who are unwilling to take total knee replacement, but tramadol plus oxycodone leads to rather high incremental cost effectiveness ratios, unless it's only being considered in those who are relatively who are after age 70. With all the successes in campaign that go toward eliminating opioids in management of chronic pain, there is a lot of uptake on gabapentin as an alternative to opioids. And so we decided to do an analysis looking at the value or cost effectiveness of gabapentin in knee OA patients. So we looked at 3 strategies: usual care, which is gabapentin spared; targeted gabapentin, which provides gabapentin plus usual care for those who screen positive for nociplactus pain using the modified P-Detect questionnaire; and universal gabapentin plus usual care to everyone. So again, because the gabapentin does carry a non-trivial side effects, including the mental health considerations and suicidal ideations, we showed that it had been dominated, so it would cost more but provide less benefit compared to usual care, which is gabapentin sparing, and therefore we said that it's unlikely to be a high value care in people with OA. Well, now that we sort of dismissed from the cost effectiveness point of view a number of pharmacologic regimens, what about injections? So based on the previous work that we have done, we show that, you know, those pharmacological care only lasts people about 3 years. And so most of them is going to consider injections. And so what we did is we considered a number of strategies. Most of the previous cost effectiveness analysis only considered one or two injections. And so we compared strategies, including no injection at all, saline, placebo. That's a good, interesting separate topic for hopefully for the seminar, you know, the use of placebo in management of knee OA, corticosteroids, hyaluronic acid, and PRP. Okay, well, let's start with the cost. So the idea of saline costs nothing and corticosteroid are very inexpensive and HA and PRP more expensive, I think needs to be dismissed because both saline and corticosteroid as well as HA and PRP carry the cost of administration, and those costs are non-trivial because they include the doctor's visit and administration of the injection, and so the cost ranges from $300 to about $2,600 for PRP, and saline being the least expensive, but obviously it's not being offered in a day-to-day practice. So here is the results of the cost effectiveness analysis, and we've done it looking from two angles. So there is some evidence, and again, it's a little controversial, but it's building. So we're following and watching this, that the frequent use of corticosteroid injections increases the risk of OA progression. So we did analysis kind of in two options. One, that corticosteroids do increase the risk of OA progression, and another one is trying to see if corticosteroids do not increase the risk of progression. And now I'm seeing that, you know, my slide had been cut off a little bit. So if assuming that corticosteroid injections increase risk of OA progression, then corticosteroid injections are being dominated, and HA is considered, you know, if we have the $100,000 as the willingness to pay threshold, then HA is considered to be, from that perspective, a high value care or cost effective care. If our threshold for willingness to pay will go to $150,000, then PRP could be considered. But if corticosteroids does not lead to increase in OA progression, then it shows to be very, very cost-effective option. The last segment, let's move to surgical interventions. They're the most invasive, but, you know, most efficacious. And we'll start with, again, a controversial subject of APM, because there is a number of trials that had been shown that incremental efficacy of APM is either very small or does not exist. Again, incremental, both conservative treatment and APM lead to improvement in pain in those with OA and concomitant meniscal tear. And so the question is, and there is a number of countries, European countries, that issue called that, you know, APM should be taken off the formulary for treatment of symptomatic meniscal tear, and definitely not being used as the initial regimen. So we decided to look at this question from the cost effectiveness perspective and looked at three strategies: physical therapy alone, which means APM is not an option; physical therapy followed by APM if subjects continue to experience pain. We called it delayed APM and immediate APM. And so now you're kind of very familiar with the format for cost effectiveness. So compared to PT only, so PT plus delayed optional surgery led to cost effectiveness ratio of $31,000 per quality. And compared to that, immediate surgery led to the incremental cost effectiveness of $3,800 per quality. So it's clearly that immediate surgery is not offering a good value care, but physical therapy followed by optional surgery, would it show a favorable cost effectiveness ratio? And so the question is, are we ready? Do we have enough evidence to cross off APM from a high value care list? So when we don't have very good data, or there is a lot of uncertainty, then we do a probabilistic sensitivity analysis looking at this. What is the likelihood of the strategy being cost effective? This likelihood is expressed in y-axis, compare or depending on different willingness to pay thresholds. And so if we look at this dashed line with the PT plus optional surgery, so we actually seeing that the likelihood of this being cost effective is reaching about only 50%. So there is a lot of uncertainty with respect to cost effectiveness of the strategy, and we do need to collect more data. So hopefully we will have some additional clinical trials considering or examining the efficacy of delayed surgery among those who failed initial PT. There is a lot of advertisement. There is a lot of work by the device manufacturers trying to say that our implant is better, trying to win surgeons' hearts. And so the question is how to place a price in medical device innovation. And so what is important to recognize in total knee replacement that we're starting with very good procedure. And if we look at different groups of patients, so we consider the 50 to 59 healthy, and another group is 50 to 59 with comorbidity. Then the next two groups, 70 to 79 healthy and 70 to 79 with comorbidity. So we'll see that the likelihood of dying within 5, 10, 15, and 20 years is far exceeds that's depicted by the wide segments of this graph, much exceeds the likelihood of being revised. So this is with the currently available implants. And so from that point of view, so the question is how much those implants need to become better with respect to how much the cost should be increased in order to justify it from cost effectiveness ratio. And so again, this is another angle to look at the data. So in order to, so the proportion who receive a revision with standard implant within 20 years, it's only about 18% if they had total knee replacement between 50 and 59. And it goes to 9% if they receive the total knee replacement between ages 70 and 79. So giving such a small risk of revision and competing risk of death, which is much higher, those innovative implants need to be much more efficacious in order to decrease it substantially. But even there, so the most evidence it will have in was the opportunity to decrease the risk of revision only in 50 to 59 years old healthy individual, and the risk of revision can go from 15 to about 7%. But again, so that is assuming that it leads to 70% decrease, which is we have not seen any data on that. So the innovative implants might decrease actual TKR failure, not just radiographic wear, by 50 to 55% or more over standard implants to be broadly cost effective. And comorbidity and remaining lifespan significantly affects innovative implant cost effectiveness and should be considered in the development, approval, and implementation of those novel techniques. And I know that surgeons are and institutions are dealing with this to make sure that the cost of implant is consistent with their value. So the next controversial question is, should we offer total knee arthroplasty in person with BMI greater than 40 kilograms per meter square? And again, it depends. There is a lot of discussions in the realm of fee-for-service versus bundle payment, because obviously people with BMI greater than 40 have diabetes. Many of them have diabetes, and they have a higher chance of complications. And so that led to some institutions and surgeons feeling uneasy about offering total knee replacement to those patients. From another regards, the risk of complications to total knee replacement, even among those with excess weight and class 2 and 3 morbid obesity and other comorbidities, they still relatively rare. And so we thought to do a formal cost effectiveness analysis looking at the cost effectiveness of total knee replacement in these populations. And what we found that the excess weight should not be an exclusion based on cost effectiveness ground. So the cost effectiveness ratios for total knee replacement was favorable depending on the willingness to pay of $100,000 per QALY saved in all this population group. But this is only from cost effectiveness point of view. And again, the decision to offer or undergo total knee replacement obviously need to be based on the discussion between the surgeon and a patient. What about the surgical weight loss in knee osteoarthritis? So we showed that the non-pharmacologic weight loss is very cost effective, but there are some people with very high excess weight that probably non-pharmacologic regimens are not going to help them to get the sufficient amount of excess weight. And so we examined the cost effectiveness of bariatric surgery, and we looked at 2 surgeries on the laparoscopic sleeve gastrectomy and Roux-en-Y gastric bypass. And so what we showed is that the Roux-en-Y gastric bypass was very cost effective among people with the BMI greater than 40 kilograms by meter square, contrary to what is being promoted by surgeons that sleeve is a safer option. It is safer, but it just does not provide enough benefit to bring the excess weight down. So the sleeve does provide good value among those with BMI between 35 and 40 kilograms per meter square and osteoarthritis. So let me finish with a few parting thoughts. Determination of value of care should include economic evaluation, and non-pharmacologic management, diet and exercise effective and offer a good value. While implementation of non-pharmacologic regimens remains challenging despite offering good value. Current options for pharmacologic management of knee OA are limited for short-term pain relief, and gabapentin opioids do not offer good value for knee OA. Short durability of pain relief and chronic nature of OA leads to opening door for regimens of questionable value, and in the absence of long-term studies on safety and efficacy, and in the face of direct-to-consumer advertisement. And so we should be kind of aware of that. And also lead to greater utilization of total knee arthroplasty. APM may be a valuable option as a second line. RCTs establishing APM efficacy among those with PT failed is needed. Total knee arthroplasty is high value regimen even in person with OA and obesity. And how much effort should we spend on developing novel implants for TKA? Should depend, and we need to realize that TKA with plain vanilla implants offer good value. Most likely implants will live longer than patients, and higher cost of novel implants, especially in older patients, is not justified from cost effectiveness perspective. And I would like to leave you with a few important, from my point of view, take-home messages. It's a common misconception of cost effectiveness that cost effective means cheap, and cost effective saves money. So the reality is that cost effective does not mean cost saving. Remember those different quadrants. So cost effective means that it will cost more, but it will offer additional benefits. So cost effectiveness is a value of additional benefit compared to additional cost. The next common misperception is if an intervention is cost effective, payers should be willing to pay for it. I touched upon it a little bit. So that's not enough just because it's the first step. Payers need to understand what's the affordability. And I think that's the different analysis, which includes the budgetary impact. That is a different methodology, but should be accompanied by cost effectiveness analysis. Cost effectiveness depends on the perspective of the analysis. Cost effectiveness analysis attempt to account for all costs and benefits regardless of payer or beneficiary. Cost effective from societal perspective does not mean budget neutral from the payer perspective. That's important to recognize when we present it to payers. And it still leaves unaddressed the question of where the money should come from. And we know that that's an important question. The third common misconception is that cost effectiveness is the best way to make all resource allocation decisions. That's not true. You know, we live in the era of limited resources, so we do need to consider the economic considerations, but cost effectiveness is one of several considerations. Ethical considerations, equity and access to care, implementation challenges, and political considerations do play an important role in our policy decisions, at least in this country. And I would like to end with, again, acknowledging the funding from NIMS, Arthritis Foundation, and Pfizer for the project of societal burden of opioids. And it takes a village. This is the list of people who contributed to all the work of the project that I listed, or the project that we currently working on. And it's a very long list, and many thanks to all the last comments, all the research assistants that had been trained and worked in cost effectiveness analysis. Many of them are now, you know, physicians, and hopefully will implement all the interventions that we showed to be of high value. So, thank you.
Thank you so much, Elena. That was fantastic. I don't see comments or questions in the chat yet, but it's hard for me to imagine that people don't have questions, comments about all of that great work. And Sandra, why don't you go ahead and go first?
Thanks, Kelly. Thanks, Elena. That was really great. I was wondering how you mentioned that it's muddy and we don't have sufficient evidence for certain recommendations, for certain, you know, conclusions about cost effectiveness. I'm wondering, in the realm of behavior change, physical activity maintenance, what do you think are the gaps in our understanding of cost effectiveness when it comes to maintenance?
So this is an excellent question. So for maintenance regimens, in order to establish cost effectiveness, we need to first establish effectiveness. And I think that's where the gap is. While we have a number of studies showing the showing the effectiveness of weight loss program, I think they leave people 6 months later, 18 months later, saying, okay, you know, people, this program is effective, but we don't know what's the value of the maintenance program, primarily because we don't have too many maintenance programs that had been evaluated. But we also need to recognize that the maintenance is usually kind of the way that we can express benefits are slightly different, because when you change the category from being from morbid obesity class 2 to morbid obesity class 1, so there is some data to support the difference in incidence of comorbidities or morbidity and mortality. When you maintain, that means that you're actually expending money for, you know, keeping the status quo. And so the efficacy of such intervention just need to have more creative matrix to establish it. So it's the not regaining weight, but again, I think it's a very important area, but we should spend more time thinking how to present first effectiveness of it, and after that, you know, working on the economic benefit. Lee.
Just following up a little bit on what Sandra said. So we know that, do your assumptions with the weight loss and exercise assume people stay in, like if they move from class 2 to class 1, that they stay in that forever? Because we know most people go back within a few years, and sometimes go back to even a higher weight.
Yes. This is excellent question, and that's the one that we give a lot of attention to in all our programs. In all our modeling projects, we take into consideration regain. And so we trying to use the data for bariatric surgery. We use the data from the large lab study, which show the trajectory of regaining. From the diet and exercise program, we use the data from IDEA, which showed the data on 5 years. So we have regain from all programs. And again, so I think we're trying to be very conservative and do not try to propagate that the benefits stay forever. In fact, we do know that unfortunately short-term programs only lead to short-term benefits. And so that's why I think we critically need the maintenance support. And we need to establish the efficacy first, because without the efficacy, we can do what if analysis, and what if analysis can say how good the program should be, depending on how much it costs, in order to be cost effective. So perhaps we should do that rather than waiting for great studies on maintenance to be done, because they first need to be funded and then to be done. So maybe that's the next step that we should consider.
So actually 2 questions in the chat. Maybe we can try to, I think we can do them in 3 minutes. The first from Jason, any insights from the hip universe? And then Becky has a question about, given the cost effectiveness of weight loss, any plans to study GLP-1 agonists?
So let's start with the hip universe. So I think that, we learn a lot from building the model. And again, it's very detailed on the knee realm. I would be careful, try to imply that all interventions that had been shown to be cost effective or not cost effective, probably not cost effective. I would feel more comfortable to say that it's unlikely that gabapentin and opioids will be cost effective for hip OA. I think the surgical interventions, I think, we need to repeat this analysis. And I think that it's always a question about the opportunity cost, where to spend effort. We are funded to do knee, we're not funded to do hips, just because I have only limited resources, as we all do. But I think if that's something, if there is a funder who would like to consider funding the hip work, I think we would be open. And I think learning so much from knee, I think we can extend it to hip at the fraction of the cost. Amanda, yes, glad you asked about GLP-1s. That's exactly what we're doing right now, and that's exactly what AF offered some funding for us to do. It's interesting. It's not, I don't want to to give it all away. I think we will be submitting abstract to ACR, so stay tuned. It's complicated, and based on our preliminary results, given the current cost, GLP-1s are not clear, does not have the clear evidence of being of a good value in people with OA and excess weight, especially when you put the bariatric surgery into the mix for the same reason of sustainability, because we do see the data that's showing that it's expensive. And so bariatric surgery, you do it once and you carry the benefits for quite some time with some regaining. But with GLP-1s, you do need to pay $1,000 every month. And the moment you stop taking it, there is a high likelihood of regain. So yeah, stay tuned. You're going to see these results in November in DC.
All right, we've got one more comment from Jason in the chat. Have you thought about inpatient versus outpatient total knee replacement costs? Interesting. Current issue because CMS is trying to move to care outpatient.
Absolutely. We just got refunded to look at exactly this, and we're starting this analysis because first we need to assemble good data showing comparing apples to apples, because most of the data one day outpatient versus inpatient focused on slightly different population. Yes, it's exactly, we're starting this project right now.
All right, Louise, let's squeeze one more in real quick.
All right, I'll try to ask it fast. I often try to think about how to translate some of this information to clinicians as a physical therapist. And one tension that I always have about thinking about this is a lot of the cost-effective models, and I appreciate they're from societal and system perspectives or over years, but from like a patient perspective or a provider perspective, I don't think they necessarily capture like the benefit of getting better faster, or the value of that. And I just wondered about your thoughts on how do you kind of capture that, and particularly because I think that's useful when you're communicating with like other clinicians and patients.
I think this is a very good question. So cost effectiveness analysis is a policy analysis. And so the policy, analysis by defining what policy is, it's for policy making and policy informing. That said, I think it's important for patients and physicians should make the decisions about which treatment to take based on the shared decision-making strategy, where the physician offers all the information or evidence that he's aware of, and with pluses and minuses, including getting better faster. and that, they need to make this decision. To that regard, that's why, I am, being a proponent of, if there is evidence of low value care, policy or payers may refuse paying that, but it does not mean that the patient should be refused for considering this option. If a person would like to put out money out of their pocket to pay for something that they perceive as effective to them, I don't think that it should be a policy of do not do unless the harms are much exceeding the benefits. But even that should be a patient decision. It's the payment that should be based, payment that is conducted by payers should be based on the value information. But I don't think that we should be in a position to say this treatment is off the table because it's not cost effective.
Thank you.
Okay, I think we run over. We started on time. It's a good policy to end on time as well.
Yep. Yes. Thank you once again, Elena. Really
Okay,
appreciate it.
thank you.